Guys, this is Mrs. Egler, and this chapter is chapter 37, a urinary elimination. I'm going to do the voiceovers just a little bit different for this chapter. Many of the chapters you've went through, you may have, or if I have lectured them, I may have kind of reviewed the anatomy that's at the beginning of your chapter. And this chapter starts out the same. It starts out with the urinary system. It's made up of the kidneys, the ureters, the bladder, the urethra. You have had anatomy, and you can review that basic anatomy here in these slides on your own. I'm not going to do any voiceover on those slides for this PowerPoint. So the next PowerPoint where you will hear me talking will be on slide 6. So go ahead, take a few minutes, review your anatomy, and we'll resume on slide 6. So now that you've reviewed your anatomy over the urinary system, we're going to dive right in with urination or voiding. And although this is reflexive, we can learn control. The act of urination requires us to use our detrusor muscle. It contracts. We have an internal sphincter that relaxes and urine moves into our posterior urethra. Muscles of the perineum and external sphincter relax. Our abdominal wall muscles contract and our diaphragm lowers. And this allows us to void. A few definitions, and the reason I started on this slide, just for you to be aware of, is urinary incontinence. We're going to talk more through this PowerPoint about urinary incontinence, but just be aware urinary incontinence is any involuntary loss of urine. And then the other term on the slide to be aware of is dysuria, which stands for, is the definition for that word is painful or difficult urination. The frequency of our urination really depends on the amount of urine that is produced. When we are, we're going to get into urine testing, and for some urine testing, we do want the first void of the day because that void of the day is usually the most concentrated. Infrequent voiding is usually secondary to low fluid intake, possibly inaccessibility of toileting, work circumstances. Nurses tend to have infrequent voiding just based on the work they're in and how busy they are. Illness can also impact infrequent voiding as well as limited mobility. When we have an individual who has infrequent voiding, it does place them at higher incidences for a UTI or a urinary tract infection. It can also indicate with infrequent voiding that they could possibly have a renal or circulatory disorder. The next concept to think about when we think about the frequency of urination is urinary retention. And this is when we produce a normal amount of urine. However, we're not excreting it fully from the body. This can be secondary to medications can cause this, as well as a large prostate or a vaginal prolapse, tumors, bladder nerve damage, and kidney stones. A lot of times, if we have a male individual who's suddenly having urinary retention and they're of a certain age, we will automatically think, could this be possible related to an enlarged prostate? And that would be something to rule out. So just be aware when we're thinking about the frequency of urination, the problems that are associated with infrequent voiding as well as urinary retention. The next few slides we go through are going to discuss some developmental considerations when it comes to our urinary system. We are all born with involuntary control of our bladder. Usually voluntary control normally occurs between the ages of 2 to 5. Before the toilet training can begin with a child, or before it should begin, The child needs to be able to hold their urine for about 2 hours. They need to be able to recognize the feeling of bladder fullness, be able to communicate that need to void, and then control their urination until they get to the toilet. So, again, we are not automatically born with voluntary control, but it is something that we can learn, and the typical age for that is between 2 and 5. Other factors that affect our urination, of course, are aging. As we age, things just stop working or decline. Um, Physiologic changes that accompany normal aging may affect urination in older adults. Nocturia is a very common finding in older adults, and this is just diminished ability of the kidneys to concentrate urine, and it can result in a lot of nighttime urination. Along with that, we have a decrease in our elderly with their muscle tone, and that can cause problems with the capacity to hold the urine. And this can result in the patient or the older adult having increase in frequency and having to go to the bathroom. As well, with aging, we can have decreased bladder contractility, and this can lead to urinary retention and stasis, which increases likelihood of urinary tract infections. So if we cannot get that urine out and it's just sitting in our bladder, it's very prone to cause UTIs. And we see that some because of that decrease in bladder contractility in our older adults. We also can see with older adults, they may begin to have some neuromuscular problems, degenerative joint problems, maybe even some alteration in their thought process and weakness that can interfere with that voluntary control and that ability to reach the toilet. As well, as we get older, our health declines, we may need medications for other health problems, and this too may interfere with bladder function. And I give an example here in parentheses of diuretics. So I know you don't have pharmacology or haven't had pharmacology yet, but a diuretic may be prescribed if we're trying to get fluid off of a patient. You may hear an elderly person refer to that as a water pill, and this will make them have a lot of frequent urination. We usually tell elderly to try to take this medication in the morning, but if for some reason they took it later in the day or in the evening, then this may be causing them to have increased urination through the night. And so that's just one example of a medication that can interfere with the bladder functioning. Another factor that can interfere with fluid or with urination is our food and fluid intake. And when we think about intake and output, so what we drink and what we void out should be about equal. So if we are dehydrated, the kidneys will reabsorb that fluid. Our urine may appear more concentrated, so it's going to be more yellow, and we may see a decrease in that amount of urine. As well, the kidneys excrete large amounts of fluid in fluid overload. So again, the amount of food and fluid we intake are going to impact our urination. As I said earlier, with elderly, they may have a decrease in muscle tone. Activity and muscle tone are important. As we know, exercise increases our metabolism, it will increase our urine production, and it really helps our urinary system maintain its optimal function. So if you have that individual that has some immobility issues, you may see that they start to have a decrease in their bladder tone and their sphincter control. As well, further in this PowerPoint, we're going to talk about what an indwelling catheter is. And when an individual has an indwelling catheter, this can decrease the bladder tone because the bladder is not being stretched and it's not filling completely. And it causes it kind of to lose its tone and not function as easily after that indwelling catheter comes out. Other causes of decreased bladder tone that can affect our urination is childbirth, trauma to the muscles, muscle atrophy. So just to be aware that these are factors that have an impact on urination. medical conditions or pathologic conditions can impact our urination. Um, One such type of medical condition, renal failure. This is failure of the kidneys to be able to remove waste. And there's two types of renal failure. Acute, which is just a sudden decline in function, and this could be secondary to dehydration, inflammation of the kidneys, a ureter obstruction. Acute renal failure is reversible. We can fix this and we can fix this problem. Those that have chronic renal failure, this is going to cause irreversible kidney damage to the kidneys. We cannot reverse this. And chronic kidney failure tends to develop very slowly. There are medical conditions such as diabetes and hypertension that can impact and cause chronic renal failure. So again, these conditions can impact our ability to void and urinate. This slide has medications listed here. It gives you some classifications, anticoagulants, diuretics. And the reason the slide is here is not because we want you to memorize these. We're not going to ask you what color does a diuretic make urine. We don't want you memorizing things like that, but why it's here is because we want you to realize that medication can cause changes in the appearance of urine, and it can also cause kidney damage if we're not careful with certain medications and watching that. So just to be aware, that's why this slide is here, is to kind of highlight, hey, here's some example of medications, and here is how it impacts the urine. And so it's just more informational. Again, you do not need to memorize these medications. So if a patient comes in and we're concerned about urinary, it's important to figure out what we are going to assess for. And we first need to start out with a nursing history. And so some of those questions you are going to ask when you're performing a head-to-toe assessment. So again, when we are doing our head-to-toe assessment, we should be asking, when was the last time you voided? We should be asking, did your urine, what color was your urine? Have you noticed you've had any increase in frequency or decrease in frequency? What was the amount? We can ask questions, have you noticed any recent changes? Or what is your usual pattern? Are you having any problems with nocturia? We also, when the patient is admitted into the healthcare facility and we're taking a history on that patient, we want to know if they have a history of any urinary problems. When we're performing our physical assessment, it is important to know that the bladder position, we can palpate a bladder when it is full. I don't highly always recommend this for a student to do, but it is possible to palpate that bladder when it's full. It is important, as I said in the last slide, to ask the patient when they voided last. We have, and this picture here shows this, the ability to scan a bladder, and that is what this device is in the picture that the nurse is holding. And it's just an ultrasound that can create an image of the bladder, and it can give us an estimate of urine volume. So it's very non-invasive, painless. There is a review of the skill. I've listed some page numbers here. But it is a way for us to assess. So if we have a patient that tells us they haven't been able to void or they didn't feel like they emptied their bladder completely, this is another tool that we can do. We can scan their bladder and we can see if there's any urine left in that bladder. As well, for doing a physical assessment, your book talks about assessing the urethral orifice. And we really... during your head to toe, this may not happen, but if you're assisting a patient with a bath, you may be able to inspect that area for any inflammation or discharge or odor. For a man, if they have their foreskin still there, an uncircumcised man, you may have to retract that to look at that area. And it's always important to note that if you have an uncircumcised male, that you do need to, after you retract that foreskin, place that foreskin back over the penis in normal position following your assessment. We don't want to leave it retracted. But these are things that you would want to observe and ask about in your head to toe assessment. If we're concerned about urinary problems, we want to assess the urine characteristics. And so that means making a note. If we are concerned and we do want to assess these things, we may have to have a patient use a hat in the toilet so we can obtain that urine. And we want to look for the color. Is it look pale yellow to clear? Or does it have an amber appearance to it? Is it appear dark? These type of things should be noted and documented. Do we notice that urine has an odor to it? If we're concerned about a UTI, we may want to check using a point of care test the pH of that urine and the specific gravity. And then we want to know also, does it have any constitutes in it? And so that would be any possibly pus or bile or something that we note that's in that urine, and we would want to document that. So it's important that we're looking at the urine characteristics on a patient that we have concerns regarding their urinary system. I am sure you will go over many of these devices in the skills lab. At least that is my hope. But this is in your chapter, and it's just talking about how can we measure output on our patient. And if we have a continent individual, we can have that patient, as I said in the last slide, we can have them void into a container, whether that's a bedpan, a hat, a urinal, and we can collect that and measure that urine so we can determine accurate output for that patient. If we are having to pour urine into a graduated measuring device so we can measure it, we want to make sure when we're looking at the graduated measuring device that we're placing it on a flat surface so we are getting an accurate reading when looking at that. And then we want to discard the urine appropriately in a toilet. If we have incontinent individuals, we may want to make a note of kind of when the times the client tends to void. We can also, if we need strict INOs, we can consider possibly a temporary catheter. Again, we'll talk about catheters a little further in this PowerPoint. Another thing we can do if the patient is incontinent and we do need to know that output is we can place a pad in the bed, and what we can do is if the patient is incontinent and voids in that pad, we can weigh that pad wet. We could also weigh that a separate pad that's dry and subtract the difference and calculate the output based on that. So those are just some ideas. If you do have an incontinent patient and they do void in the bed, you still would want to note the odor and the color of the urine. And then measuring output of a catheter bag. There's a picture here at the bottom of this PowerPoint. And again, you want to make sure anytime you're dealing with these devices and urine, you want to make sure you're washing your hands and you're putting on gloves. And you're just going to empty that bag into a graduated device and measure it. The big thing about once you've emptied that bag, you do want to make sure that you clamp it back so that doesn't continue to pour out of the bag as it drains the bladder. And put that clamp device back into the holder that is made for it on the urinary bag. If we need to do a urine collection, because we need to run a lab on that, this slide consists of different specimens and how to obtain them. For any routine urinalysis, we do not need a sterile specimen. So we can have that patient go and they can void in their bedpan or their urinal or their hat, and we can pour that into a lab container, label that with the patient's information, and send that down to the lab. The important thing is once we gather that, we don't want to leave it standing very long at room temperature. So it's important to have the patient call out. If we know we're trying to collect a urine sample, have them call out when they void so we can immediately go in there and obtain that and send that down to lab. The other thing that's not on this slide is if you have a woman who is menstruating, you need to note that on the label so that they know that and that suddenly doesn't become an abnormal finding with their urinalysis. There are times when we do want a clean catch midstream, and so we have to do some education to teach the patient what we need with that. You would have the patient void a small amount, they need to stop midstream, and then they need to void into the container. And for that test, we need about 10 to 30 mLs. And I believe there are some guidelines for that. I have it here, 36-1, on how to obtain that. If we need a sterile specimen from a patient, then we have a couple of options. We really need, if they don't have a catheter in, we need to obtain what's called an in and out catheterization. And again, we will show that in a little bit in a different PowerPoint, what that looks like. And that procedure, and you will be learning how to put a catheter in a patient. But in and out catheterization, we are using sterile technique to clean the patient. We are keeping the catheter sterilized. An in and out catheter does not have a bag at the end. So that catheter is going to be inserted into the bladder, and then we'll need to obtain a specimen cup at the end to collect that urine and keep that sterile. If they have an indwelling catheter, we can still get a sterile specimen from that. And what we need to do is we need to clamp the tubing below the collection port. And we clamp that for about 30 minutes prior to collection. And then we can use a syringe. We can attach it to that port and we can aspirate urine into the syringe. The big thing is you cannot leave that catheter clamped for more than 30 minutes. It can cause that urine to back up in the bladder. It can lead to UTIs and lots of other problems. So we can obtain it, but we have to be aware of the time and how long we've clamped that catheter. But a sterile urine specimen can be obtained with an indwelling catheter. I put a few other things on here. I'm not going to get too much into the urine specimen with the diversion device. You've got that. It's in your book. I did put a small picture here of infants and children. If we need a urine sample on a patient that is incontinent, like a child like this that hasn't learned bladder control, there are other methods like a collection bag that we can stick to the area that when they pee in, then we can pull that off and we can send that down to lab. The last test I really want to talk about, though, is the 24-hour urine specimen. And so this test, you will start it, and most of the time we try to start it with the first void of the day, but you can start it whenever you're directed by the order. But we want to collect 24 hours of urine and then send that down to the lab. With a 24-hour urine, we always have the patient void at the start of the test, and we actually throw out that first void. Then after that, for 24 hours, it's very important that every time that patient voids, we collect it and we put it in the 24-hour urine specimen container. Usually we will keep that container on ice or place in a refrigerator somewhere. And then once the test is complete, after 24 hours, we send that immediately to lab. It is very, very important that we educate our patients with a 24-hour urine specimen test, that we place signs all over the room for that patient so that everybody is aware that we are collecting that urine. Because at any point during the 24 hours, if a urine sample gets thrown out on accident, you have to restart the test, and it's not a good process for the patient. It prolongs them getting their results from this and what they're trying to find. So again, if you have a patient on 24-hour urine, very important to educate the patient as well as pass that along to the rest of the staff to have signs everywhere for the need to collect that urine for that test. So, as I was talking about earlier, and when we were talking about the characteristics of urine, this point of care testing for urine, we always want to follow our facility or company protocols and make sure we've been trained properly. But um, this is what the test looks like. It's little strips. Normally, if you're going to run one of these, the patient voids. Um, you take the specimen, you dip the dipstick in it, and you compare it to the colors on the bottle, and it will give you an estimate based on the color what the pH is, if there's ketones in the urine, and things like that. And so sometimes this is beneficial. I worked as a school nurse for many, many years. I had diabetic kids in the office. If their blood sugar was extremely high and we were treating that and they had several high blood sugars in a row even after treating it, we would usually do a point of care test to see if they had ketones in their urine. So it is something that you may do in an outpatient type of setting where you work or within the hospital. This slide is here to talk about some of the common diagnostic procedures that a patient may have with urinary issues. You can read this. I don't want to spend a ton of time on it because the information is here for you to look over. It's also in the textbook. The biggest thing I want you to have a takeaway from with this is just being familiar with what these tests are for. What are they testing or looking at? For example, a urodynamic study, we're looking at and measuring the flow of urine. So before this test can be performed, that patient needs to have a full bladder. And oftentimes we can get this by having them drink a glass of 8 to 10 ounces, 8 to 10 8-ounce glasses of water in a 24-hour period. Should be done following the test, but we can get them to drink some water, hold their urine, but again, their bladder has to be full to measure that flow of urine. A cystoscopy is that direct visualization of the bladder, the ureteral orifices, and the urethra. It does require a physician's order and a signed consent form. Some mild sedation is given. The bladder is, in order to do this direct visualization, I can't talk tonight when I'm doing this voiceover, I'm sorry. But we have to fill that bladder with sterile solution. An intravenous pilogram is a radiographic imaging of the kidney and ureter. Again, a consent is needed. We also have to assess for an iodine allergy with those. It is contraindicated for patients that have an elevated BUN or creatinine, or if they're pregnant, we would not want to possibly do this exam on them. The retrograde pilogram, again, you have this here. We're imaging of the kidneys and the ureter. Contrast is directly injected into the ureter for that exam. A renal ultrasound is non-invasive. It's just a visualization of the kidneys, but a signed consent is needed. A renal ultrasound differs from the bladder scan that I referred to earlier in this PowerPoint. A CT, again, is a radiographic exam. Consent is needed. We have the patient be NPO 8 hours prior if we're going to use contrast in that study. And then a renal biopsy, where we're going to take a small piece of tissue and we're going to send that to the laboratory for examination. And that is obtained through a needle with a skin puncture or incision. Again, you will need a signed consent for that, and sedation may be necessary. So just familiarize yourself with what the common diagnostic procedures are and what they're looking at. So if we are concerned with a patient having some urinary dysfunction, we need to try interventions for our patients. And so one of the things we will want to work on is maintaining a normal voiding habit. So we want to make sure we keep our patients on a schedule and support their normal urinary patterns. You know, again, in the clinical practice, it's good to hourly round on our patients to check if they need to go to the restroom. We want to have our patients at the first urge to void to assist them when they feel that and have them void. We don't want them to hold their urine. We're going to try to provide them as much privacy as we can, but we also have to remember we have to maintain safety. Um, Position, we're going to help our client assume the most natural position that can be tolerated for that position for that client so they can void. If we can sit them up, if they have to use a bedpan, but we can sit them up in the bed, we're going to try to do that because that will help with maintaining their normal voiding. And then hygiene, if we have a patient with limited mobility, they may need some assistance with cleaning that area after they are done voiding. And the other thing to think about is if your patient's using a bedpan, they're trying to wipe themselves, or they're using the restroom and they're trying to wipe themselves, or even a bedside commode, are we offering them to wash their hands in some manner? We want to make sure we are providing good hand washing for our patients. Continue on with interventions. We also want to promote fluid intake. We want to encourage those patients to take at least 2,000 to 2,400 mLs of fluid daily, and that should be for a normal adult with no restrictions. We do have patients with kidney issues that will have fluid restrictions, and we will have to abide by those, but for our normal adult, we need to promote that fluid intake. And with that, that means 8 to 10 8-ounce glasses. Water is always a best. We want to encourage water. It's okay if they have some coffee or tea or soda, but we also want to encourage them not to indulge and have too much of those. Water is really the best. We have a patient who's having issues with muscle tone. We can also strengthen that by teaching them how to do Kegel exercises. This will help greatly with stress incontinence. We have our patients contract their pelvic muscles, and we have them do that for about 10 seconds and then relax. They can do these exercises anytime while they're laying in bed or sitting up in a chair, but we want to encourage them to try to incorporate into a daily routine so that they are working on strengthening that muscle tone. We're going to assist our patients when needed with toileting. Safety is always a first concern with that. If we have a patient that needs assistance and we're going to ambulate them or get them up, we're always going to use our gait belt and walk beside that patient. We're going to encourage the client to perform as much of the process as they are capable of, and then assist them if, for instance, they need assistance with wiping or washing their hands or whatever that may be. But we want to encourage them to do as much as possible. This is an example of a bedpan. This is what, there's standard bedpans and then there's fractured. This picture is one of a fractured one. You would use this especially for clients with fractures to the femur or spine, but I've also just seen this as being the general bedpan on most hospital units that we give patients. We want to, again, work on maintaining privacy, and there is a skill for you to review regarding assisting with toileting. We're getting ready to move on to some conditions that affect urinary function, such as urinary tract infections and incontinence. But there is something I wanted to mention that I did not mention on the last slide was the use of bedside commodes. There is not a slide in here, but your textbook does talk about a bedside commode. It is on page 1359 along with a picture of that for you to see. But bedside commodes sometimes work really well for that patient that we want them ambulating a little bit. We want them to get up, but they're just not strong enough or not really able to walk all the way to the bathroom. Then a bedside commode might be a really good option to transfer them. It sits almost like a chair you can put it next to the bed, and you can pivot your patient on it. And it's just, we want to encourage that. If we can have a patient void, it's much better or more natural for them to sit up on a bedside commode versus trying to use a bedpan. And again, this is all dependent on your patient and their ability to get up, what their physician orders are for activity, etc. Now moving on to this slide, urinary tract infections. UTIs are the second most type of infection. They can lead or cause systemic infections in our older adults. Women tend to be at a higher risk due to the length of the urethra and the proximity of the urethral medius and rectum. Some risk factors that make urinary tract infections, or people who are more prone for them. Risk factors include sexual activity, especially in women, those that use contraceptive diaphragms. The postmenopause woman seems to be at more risk for a UTI, as well as those that have indwelling catheters. And then diabetic patients and our elderly are more at risk for urinary tract infections. Continuing on with urinary tract infections, some main points I'm going to point out on here. There is some extra information that I'm not expecting you to know. But if we suspect a patient may have a urinary tract infection, the first thing we need to obtain for that patient is a urinalysis, and we will order a culture and sensitivity. And what we're doing there is, if the urinalysis does show that this patient has a urinary tract infection, we want to culture that so we know what the best course of antibiotics are to treat that infection. Treatment includes short course antibiotics, and we also want to educate our patients on ways to prevent UTIs, or urinary tract infections. And I want you to highlight these above, are these preventative measures. One thing is to encourage our clients to drink anywhere from 8 to 10 8-ounce glasses of water daily. We also need to make sure, depending on the age of population, or what, if we are dealing with a small child, we want to make sure they're wiping from front to back. Your textbook actually says, I don't know that many people do this, but drinking 2 glasses of water before and after sexual intercourse can help that patient that is very prone to UTIs. Voiding immediately following sex, wearing underwear with cotton in the crotch of it can assist with preventing some UTIs if you're prone to that. And also, just having a 10-ounce glass of cranberry or blueberry juice daily can help that patient who is prone to UTIs. So those are some preventative measures that you can educate your client on. We're moving on to incontinence here, and incontinence is any voluntary leakage of urine, which I had stated earlier in this PowerPoint. We do see incontinence more common in women and elderly. Interventions and treatments are aimed at helping to restore the continence to that patient. Of those that seek treatment, most have improvement of symptoms, and many can be cured. There are available products for patients who are suffering from incontinence. Absorbent products are available. The big thing to teach is, if these are not used properly, if you're not changing these, they can cause skin irritation, skin compromise, and could increase that risk for a UTI. So as you're taking notes and going through this PowerPoint and listening to this presentation, I will tell you, I want you to spend some time on this PowerPoint. These are the terminology of the different types of incontinence. So you want to review these and know the differences between these types. So for instance, transient, this is just incontinence that appears suddenly and can last up to 6 months or less. Sometimes it's related to that patient having some acute illness or confusion, or maybe they're on a type of treatment such as a medication, and it may just be a short-term type of incontinence. Stress incontinence is when that person has that involuntary loss of urine during a time when there's increased abdominal pressure. So they cough, or they sneeze, or they laugh, and they will possibly leak urine when those moments. Urge incontinence is that involuntary loss of urine that occurs soon after the patient feels an urgent need to void. Mixed incontinence includes or indicates there is a urine loss with features of 2 or more types of incontinence. So maybe they are having stress incontinence and urge incontinence at the same time. Overflow incontinence, loss of urine due to overdistension of bladder. So again, if we are not emptying our bladder frequently or we can't get to the bathroom, we could have a type of overflow incontinence. Functional incontinence, urine loss due to the client's inability to reach the toilet. So this has to do with that mobility and being able to get to the bathroom in a timely manner. And a lot of times it can be related to environmental barriers, physical limitations, confusion. Reflex incontinence. The bladder empties without the client ever having sensation of the need to void. And then total incontinence is continuous, unpredictable loss of urine. It could be related to maybe a type of surgery or trauma. So again, have knowledge, know your terminology of the different types of incontinence. Be aware that you can suffer from more than one type of these at the same time. When we suspect a patient could possibly be retaining urine, they're not emptying their bladder completely. I talked about being able to perform a bladder scan on that patient to see how much urine they had left. And another, we're going to talk about this, it's called post-void residual. So if we suspect a patient, they just went in void, but we think they didn't void completely, what we will do is we'll have the patient void. We'll immediately do a bladder scan following that urination. If the post-void residual or the amount shown on the bladder scan is less than 50, this indicates that the patient has adequately emptied their bladder. If the patient results are greater than 100 mLs, we will let the physician know, and a lot of times that physician may order an in and out cath because we don't want to leave that urine retained in the bladder because of the increased risk for UTI. This is a skill in your book, so please take a few minutes to look over this skill, and please highlight this because this is valuable knowledge that you'll need as you go into clinical concerning doing a bladder scan, checking for post-void residual, and what the normal and abnormal amounts are. This PowerPoint is about treatment for urinary incontinence. These are just a few of the interventions that can be done to treat that incontinence. These are in your book in a nice box. It is on page 1362, and it's box 37-3, and it talks about treatment options for urinary incontinence. We talked about what Kegel exercises are. That is one method that can help train the pelvic muscle floor of a patient who may be having incontinence. A few others that we can mention. The biofeedback, that is just a measuring device that's used to help the patient become aware of when their pelvic floor muscles are contracting. You've got some other things. Medication can often be used, timed voiding or bladder training. And this box is nice because it explains what each of these are. So I definitely would take a look at these as far as some treatment options that can be suggested to your patient for that treatment of incontinence. For our patients that do suffer from incontinence, there is incontinence-associated dermatitis, and this is just that prolonged contact of the skin with urine or feces, and it leads to a form of moisture-associated skin damage. We talked some about this in our skin chapter, and the effects that can have. Skin care is very important, as well as the use of containment products for incontinence, and just making sure we are checking on those patients that are incontinent and changing them frequently, and using barrier creams if they begin to show some redness or inflammation, are all interventions we can do for this type of dermatitis. So now we're going to get into the different types of catheters. And so, when voluntary control of urination is difficult or maybe not possible, and we do worry about skin breakdown, another option that we can do for patients is a external catheter. So, your book talks about a condom catheter, and this is for a male patient. It's placed over the penis. And it's attached to a collection bag. We've got some pictures so you can visually see what we're talking about. Big things if we're going to use an external catheter on a male patient is just making sure the penis is cleaned thoroughly and that it's fully dried before we place that on. We really want to be consistent with checking that skin integrity because we don't want that penile area to become red or have any skin breakdown because of the external catheter. And again, there are different condom catheters out there, so you would want to apply this according to that manufacturer's recommendation. This is just another picture of that male external catheter. This is a different brand. This is one that is used at community hospitals, and there is a YouTube video you can watch on how that is applied. So this is a picture of a female external catheter. And what I want you to realize is you will not find this in your textbook. I was actually shocked. We had a new edition of this textbook, I think like a year ago, and they do not talk about female external catheters. They're fairly new on the market, but they are a catheter that we can place on a female patient. As you can see in the picture, how it is placed, it's between her private area here, and it is hooked to continuous suction. So as she urinates into this, it is going to a collection device. These are nice for patients if we're trying to avoid doing an indwelling catheter because of UTI risk. This is another option. Again, these are fairly new, and it would be the same as the male condom catheter. You would want to follow your manufacturer directions as far as the application of this device. But I just put this in here because I do want to make you aware, even though this is not in the book, that you may begin to go out to your clinical settings and see these. As we continue on talking about catheterization, it's important to note before we talk about intermittent or indwelling catheters that catheters are associated or catheter-associated UTIs are the most common nosocomial infection. Therefore, we'd really try to avoid catheterization if at all possible. There are times when it's absolutely needed, and if we do need to put a catheter in a patient, this should be performed under strict aseptic technique. Here are just some lists of reasons why we may catheterize a patient. You can read those through. But the next few slides, we're going to talk about what an intermittent catheter is and then the indwelling catheter. So I had mentioned an in and out catheter. You might also hear this called as a straight catheter or an intermittent catheter. And I talked about if we needed a sterile specimen that we would probably perform an in and out cath to get that specimen. So there is some lower risk of UTI with an intermittent catheter than with an indwelling catheter, and mostly because you insert it, you empty the bladder, and then you remove this tube. Again, this is performed under sterile technique in the medical settings, but we can also teach a client or caregiver to perform this type of procedure at home. Most of the time, if caregivers do it at home, we try to teach them just clean technique with that. But again, there is information about this. A patient intermittent self-catheterization is in box 37-4 in your book. Again, this is a really good picture of what it looks like. As you can see when I was talking about collecting a sterile urine specimen, these same type of tubing that goes into the bladder, but we don't have a bag at the end. So this is going to actually drain down in the box that it comes in. And then once you aren't getting any more urine output, you can just pull this tubing out of the patient. You will be learning how to place a Foley catheter in the skills lab. Again, we call these Foley catheters, but they are indwelling catheters. And basically, you are placing this tube into the bladder. There's a balloon that gets inflated after it's placed correctly in the bladder that's filled with sterile water. Um, and that is securing the bladder in the urethral passage or in the bladder so that it will not, blocking the urethral passage, so it will not come out. There are different lumens as far as indwelling caths. One lumen is for the balloon where you're going to hook your sterile water, and then one is for the urine that comes out. Occasionally you'll have what's called a triple lumen, and this is to allow if we need to do some type of irrigation with the bladder. The normal size of an indwelling catheter for adults is if we use a 14 to 16 French. If we are going to use larger sizes, we are posing a risk for urethral damage. And a lot of times if a larger catheter is needed, it's on a specialized type of patient. Maybe it's a difficult patient to get the catheter in. A lot of times the physicians will come do them. Again, I've repeated this several times, but I hope you will do it as you are sitting down to study the content. You really need to review your skills that are in the back of this chapter, really read through the procedure, and then really, take what you've learned from your studying your skills and from this PowerPoint and try to apply it as you practice putting a catheter in the skills lab. So we're going to move on to urinary diversions, or this is a type of urinary diversion. And what we need to realize is that we do have patients that, due to either an obstruction, possibly a neurogenic bladder, different medical conditions, make it so that we possibly need some type of urinary diversion to help with their elimination. And so for this is just one example. We have a suprapubic catheter. So this is used for long-term continuous drainage. This is something that's inserted surgically, and it's an incision above the pubis. The suprapubic bladder drainage diverts the urine from the urethra when there's some type of injury or stricture. Maybe there's a prostate obstruction, and there's some type of compromise going on. And so we have the patient have this type of diversion so that we can have them eliminate. There is associated with these are associated with decreased risk for fecal material contamination, and there is a lower risk of UTIs with this type of catheter. Again, this is for somebody who's got some type of condition where we need to divert that urine from the urethra, and so this is used on a long-term continuous drainage use. This slide is just another reminder of hazards of catheterization. As we've already stressed, indwelling catheters are very prone for patients to have a UTI with. A hazard of that can develop if the patient has a UTI. That infection can move to the bloodstream and cause urosepsis. This becomes then an emergency situation and can be life-threatening. You can cause some trauma with catheterization as well, and that can be caused by forcing of the catheters through a stricture or at the wrong angle. So there are a few hazards associated with catheterization, and it's just important to remember and practice that skill of proper insertion. I am going to go over this even though most of it we are kind of repeating ourselves. But again, I think students don't go back and really review the skills in their textbook where some of this information is. So I do want to hit on this. Most common position when we're going to insert a catheter is going to be the dorsal recumbrant. Again, surgical asepsis is needed. When we are inserting that catheter in a male patient, we want to make sure when we're putting it in that we are putting that tubing all the way into the penis up to the bifurcation, which is the wide port. And that is because we want to, and then we want to inflate the balloon because we want to avoid inflating that balloon in the wrong area. If we inflate that balloon in a male patient in the urethra, we can cause a lot of damage. And the reason I'm putting it in this PowerPoint and bringing it up on this voiceover is because this is in your skills. It does talk about this. And we've asked test questions on it before, and students have no idea. And it is important that we realize on that male patient how far that tubing needs to go in so that we avoid causing any damage. Once we put it in that far and we inflate the balloon, we can then pull that tubing back out. But that decreases the risk of us having it in the wrong area. The other thing your skills talks about, or the skills in the textbook talk about with insertion of the catheter. So for the male clients, it is helpful to gently insert at the tip of the penis some lubricant. If the lubricant comes in a syringe, it makes it really easy, and that way it's able to slide in much easier. And then just with insertion, we want to make sure we're securing that catheter to the thigh to prevent it from causing excessive force on the urethra. As we talk about the drainage system, so this is the bag with our indwelling catheters and the tubing. And again, this is in with your skills. I know you are taught that when you're watching the skill being performed, but I've seen students when we're checking them off in Skills Lab, this is one of the areas that they totally forget about. So they get the catheter in, but then they forget to take the patient's leg off the tubing. Well, if we have a kink or a blockage in that tubing, then that indwelling catheter is not going to drain the urine properly, and we're putting that patient at risk for UTI again. So we want to make sure we're keeping our patients off the tubing, that we're unkinking the tubing, and that we are keeping the catheter drainage bag below the level of the bladder at all times. We also want to keep that drainage bag off the floor, and we're going to check and make sure it's not leaking. That way, we really need to make sure that after we've emptied that drainage bag that we've clamped it well, and that, again, we aren't seeing any leaks from that. If we have a patient with an indwelling catheter, we do need to care for that. We always need to wash our hands before and after we're caring for a catheter. We need to put gloves on. We need to clean the perineal area and around the medius after each bowel movement. And when we do that, we're doing that with use of mild soap and water. We're going to rinse that well. We also, when we're doing catheter care, we need to clean the catheter tubing using a mild soap and water. Your book says not to use antimicrobial cleaners or wipes. I do know some facilities, I've heard through the grapevine with people working there, that they use HIPAA when they're cleaning their Foleys or whatever. We are telling you what the textbook recommends in practice. So they're recommending when you clean the catheter tubing, when you're doing peri-care on an indwelling catheter, you should use mild soap and water. Again, when we have a patient with a catheter, we're going to encourage activity. We're going to empty that drainage bag at least every shift, but we need to check it. If it's filling up quicker than that, we may need to empty it more frequently than that. I know the hospital, I do clinical at a lot, they instruct the staff to empty it with vital signs. So they are emptying that drainage bag every 4 hours. And we're going to record that output. We're going to keep it so that we do not open that closed system. We're going to teach personal hygiene to our patients. We're going to report any signs and symptoms of infection if we see any. And we only change catheters when needed. Catheter care and fighting UTIs with these is becoming a very big issue. Because of the cost they have on the healthcare system. So again, a lot of facilities are trying alternative measures such as external catheters, but if you do have an indwelling catheter, it is important that you are performing this catheter care at least once a shift on your patient. Removing an indwelling catheter is much, much easier than actually putting the catheter in. Again, you're going to wash hands, you're going to put on gloves. The biggest thing is you are going to need an empty syringe because you're going to need to deflate that balloon that is anchoring that Foley catheter into the bladder. So you're going to have to aspirate that liquid out that you used when you inserted the balloon. It's after you've deflated the balloon, you can have your client take several deep breaths, and while they're doing that, gently remove the catheter. Then you're going to clean the perineal area after removal. Again, we want to encourage our patients to have fluid intake. And then we have to educate our patients that voluntary control of our bladder may take a little bit of time to reestablish. And that goes back to that muscle tone. And we talked about it previously in this PowerPoint, and how when we have a catheter in there, our stretch receptors in our bladder are not being stretched, they're not being used, and they kind of get lazy and forget what they're supposed to do. So it may take some time for, again, that control to come back. The patient may complain of some burning with their first couple of urinations, and we want to observe and record any abnormalities. We also want to make sure that our patient does void after we remove this catheter. So usually we'll give them a little bit of time, but after about 4 to 6 hours, if the patient has tried, they've ambulated, they sat in the bathroom, maybe we've ran some water, and they are still having difficulty voiding, then it may be time that we have to do that bladder scan, and we're looking for that post-void residual or how much urine is being retained in the bladder. Because if we have, again, let's say the patient had a Foley catheter in, we took it out, they went to the bathroom, and maybe they only urinated 100 mLs 4 hours later. Well, we're going to check them by a bladder scan to make sure they're not retaining and to see if they have that post-void residual, if there's any of that still in their bladder. And again, back to that post-void residual PowerPoint, if we would find that they have more than 100 mL still retained in their bladder after they voided, we're probably going to let the physician know. And then there's possible that until we get their bladder back up and functioning and having that voluntary control, we may have to in and out cath them. So again, removing the indwelling catheter, not a big deal, much easier than inserting it. But again, we have to monitor these patients after we remove that indwelling catheter because there can be problems with retention of urine. On to continuous bladder irrigation. So as I mentioned with the indwelling catheters, there's different lumens. If your patient needs continuous bladder irrigation, and we often see this ordered when a patient has blood clots that that threaten to block the catheter, then we possibly will have to irrigate the bladder while we have the catheter in. So that's when it comes into play that you have those a 3-lumen catheter, and so you have a lumen to inflate the balloon, you have a lumen that urine drains out of, and then you have a lumen that we hook this bladder irrigation up that will run continuously. When you have this going, again, you're going to have to empty that closed system drainage bag very frequently. You're going to really have to keep an eye on this. And there are some guidelines on page 1372 that are very good to look at regarding continuous bladder irrigation. Your book goes on just to talk about a few more urinary diversions. I gave you an example of one a few PowerPoint or a few slides back. These are just a few other that they talk about. Again, I'm not going to go really into depth in this. The important thing is to realize that these are surgical procedures. The first one listed here is a surgical resection of the small bowel. They take a piece of the bowel and then it's used to create a stoma at the surface of the abdomen. The ureters are diverted to that stoma so that they can have urinary elimination. The next one, the ureters are diverted to the abdominal wall and they're attached to an opening in the skin, and then we apply an external appliance to be worn to catch that urine, and so forth. There's here the big thing: if we are caring for a type of urinary diversion on a patient, we really want to make sure we're checking that stoma site regularly. We're keeping that surrounding skin clean and dry. We're monitoring that intake and output. We're emptying the appliance regularly. And we're also, if they just had this done, we're going to monitor for that return of intestinal function after a surgery. We want to hear if they're having bowel sounds, especially if this is a new procedure and they've just done it. With the ileoconduit, there may have some mucus in the urine. This is normal. And we want to also encourage and teach our patients self-care of these devices. And lastly, the last slide I'm going to go over here, this is almost the end of our presentation, is just to touch on dialysis. And again, I'm not going to go into depth on this. It's just we want to give you an overview of what is dialysis. And so basically dialysis, we're going to remove the waste from the blood of the client who suffers some type of severe renal impairment or failure. So if we have a patient that's in chronic renal failure, they may need to have dialysis in order to remove that waste. Hemodialysis is a machine. Basically, a machine does the work of the kidneys. It filters the blood of the harmful waste. It requires vascular access. And vascular access, as it stated here, is an arteriovenous fistula that's surgically created, and it's a connection between an artery and a vein. You usually hear it referred to as an AV fistula. The second type of excuse me, can't talk after all these slides. The second type of dialysis is peritoneal dialysis, and this is where there's a blood vessels of the peritoneum are serve as the kidneys to remove waste, and basically we're washing in and out of the peritoneal space. Again, I just want you to, if you hear these terms, if you walk into the clinical setting and you hear, well, your patient's on dialysis, just realize there's two types of dialysis. It may be beneficial to look and see what type they are getting and have an understanding of what does that mean. Again, this is just a basic overview. We're not expecting you to know in-depth information over dialysis. That is our last slide. There's one more slide after this, and all it says is to review your skills. Again, I stressed that earlier in this PowerPoint, to look at that information when you're looking at those skills in the back of the chapter and really read what you're supposed to do. For example, how far are you supposed to put that catheter in a male patient? Those little tips, we really want you to have a good understanding of when you're working on your skills. And that concludes my PowerPoint. So thank you.